the slides. If you could just let them know while I turn on the slides here. It's posted now in the group. Okay, so I'm going to start sharing my screen again. Okay, so over to you, Dr. Fawzia.
Okay. Bismillahirrahmanirrahim. Assalamu alaikum, everyone. I'm Dr. Fawzia Naqvi, and I would like to welcome you all on behalf of CFK for this very enlightening, informative, and a very scary hot topic of the time. One day we woke up to a totally different new world. People are running towards all the grocery stores to get perishable, non-perishable items. Aisles are empty. We cannot find any toilet paper. We cannot find any hand sanitizers. A kind of like a scare, or I would say a scare is kind of like a enveloping all of us. On top of everything, we parallel to all that fiasco, we are being bombarded by a lot of information from our social media. And our WhatsApp messages are full of posts, sometimes true, sometimes fake, regarding the diagnosis, type of the virus, how to diagnose, how to treat. Somebody is asking us to start eating ginger. Somebody is asking us to start taking some honey tea all the time, up to the level that people are trying to take some chlorine showers to get rid of the virus. So I'm very happy to have Dr. Shehbaz Hasan here with us. After this session, I'm 100% sure that a lot of our confusions would have been solved, and myths can be separated from the fact. It's a very nice, very informative presentation. With that, I would like to invite Dr. Shehbaz Hasan. Dr. Shehbaz Hasan has been practicing internal medicine for the last 31 years, and currently he's been associated with the Presbyterian Hospital as as an infectious diseases specialist. So of course, nobody can talk with more authority as he can. So with that, I will give mic and all the podium to Dr. Shehbaz Hasan. Welcome, Dr. Shehbaz Hasan.
Thank you, Dr. Naqvi. Assalamu alaikum, everyone. The topic of this conversation is, as mentioned in the introduction, it's about myths and facts about COVID-19. Obviously, everyone is concerned about this illness and how it's going to impact us. So I'm just going to talk more or less about the science behind what we know about this virus, and try to separate out some of the urban myths versus what actual facts are. Next slide. Now, before you go onto social media, there are some useful websites for you to get your information. The best website is probably the CDC's own website. They have a whole very informed discussion about do's and don'ts regarding COVID virus. So when you go to cdc.gov, most of the information that everyone is discussing actually comes from the CDC website. Locally, if you want to know what's going on in the Dallas area, go to the Dallas County's website, dallascounty.org. They also have very up-to-date and very useful information about what's happening in your locality. All the different maps and graphics that come to CNN and other TV networks, they actually come from the Johns Hopkins University website. And I'd encourage you to go and see their website. They have a live, daily updated worldwide map of where the coronavirus is spreading. It's a very visual presentation. Oxford University has Our World in Data. They discuss numerous different data points about most illnesses, not just COVID, but they're also a very useful website. And for people who are interested in how we come about the calculations and the estimates about the peak of an epidemic and how the curve is going, they're actually published pandemic calculators. It's very scientifically based. It's not just guesswork about what's happening. And you can Google these pandemic calculators and it can give you an insight into how the scientists come up with their prediction models. Next slide. So the first myth, it's a conspiracy, or that the Chinese have done it, or the US has created biological weapons that have gone wrong. Some people are blaming 5G network. Religious-minded people think this is the time of the apocalypse. What we keep forgetting is pandemics are part of human history. Every time human beings interact with animals or human civilization starts spreading into places where they never had proper contact with, that is when humans and infectious organisms come in contact. And if the human community is not immune to that particular pathogen, you will have an explosion of infections. That's what happened with the Black Death. That's what happened with SARS. That's what happened with whenever influenza changes its genetic makeup. And that's the same thing that's happened with coronavirus. Next slide. So here's a cartoon of what the coronavirus looks like. It's just a schematic. And on this diagram, the diagram on the right side shows a cutout version of a representation of a coronavirus. The yellow spiky things are what we call S proteins, and the S actually means spiky protein. These are the elements of the virus that helps to attach it to the human cells. And these viruses, they attach to different receptors on different human cells. For example, the SARS virus has a different attachment site. The COVID virus has a particular attachment site in the human body. And those cells are predominantly present, those receptors are predominantly present in the lung tissue. And that's why there's a tendency for it to cause a lot of lung disease. But a virus is a very separate thing from a bacteria. Bacteria are larger, about 1,000-fold larger than a virus. Viruses are so small you can't even see them under a microscope. You have to use an electron microscope to see them. They're that tiny. And they're not living things, not like bacteria or animals. They're a very peculiar agency, which is essentially just a genetic code wrapped up by the host, which is the human cell material. So this red rim around the virus is actually, it actually comes from the animal that the virus infects. The virus itself doesn't have any capacity to have its own cell structure. It just has the gene which causes all the protein formation. Next slide. Now, where does COVID come from? Well, the coronaviruses have always been affecting human beings. All mammalian species have some form of a COVID virus unique to that species. But once in a while, the virus, it does mutate. And when it mutates, it can hop from one species to another species. And if humans are in contact with that animal species, then sometimes a mutation in that other animal species can jump to a human. And that's when human disease happens. And for example, bats are the main harbor of the the coronaviruses. And from bats, in about the year 2000, infection went to this cat-like animal called the palm civet in China. And from the palm civet, it went to humans, and that's how SARS virus came about. SARS is another form of a coronavirus, just like our COVID is. Then in 2012, bats passed on their virus, the coronavirus, to camels. And from camels, it went to humans, and that's what causes another coronavirus infection in humans called MERS. And that is why when people go to Saudi Arabia or to the Middle East, and when they return to the United States, if they're having a fever, we're always screening them for MERS, because MERS virus is still present in the Middle East. Finally, our COVID virus, it came from a bat, and it attacked this odd-looking animal called the pangolin. Pangolin is a very special, it's called a scaly anteater. It comes from South America, and for some peculiar reasons, the people in China love these animals and have started a near extermination of this species by using their scales for medicinal purposes. And it was a bat virus which went to the pangolin virus, which was in one of those animal uh, markets in China, from which the coronavirus then jumped to the humans and caused COVID-19. That's the name of the new virus species. Now, why do bats have these viruses? Well, if you look at bats, they're peculiar in the sense that they live in these enormous colonies. If you look at a bat colony, they have thousands, if not millions of bats living together, bundled up together. That means that there's a lot of infections that are potentially passing from one bat to another. So one way of fighting off these infections would be to develop a super immune system which would resist all infections. But that requires a lot of expenditure on the part of the animal species. So bats have evolved to develop a very weak immune system where they can live together with these viruses without any problems, without the virus causing them any damage. So bats have a tendency to harbor a lot of viruses. For example, bats are a common source for rabies virus, the coronaviruses. In Bangladesh and Malaysia, there was a recent Nipah virus. So bats are often the source of these odd viruses that then eventually make it to humans. It doesn't mean that you have to go around and kill all the bats, because bats have very useful functions. They do a lot of agriculture, pollination. They kill a lot of insects like mosquitoes. So we do need the bats. So don't get the impression that we're going to go around killing all the bats because of this. Next slide. Now in this table, I've shown some common comparisons between the different coronaviruses. And at the end, I've also included influenza, which is probably the main virus that we worry about every year. So for example, the SARS virus showed up in 2002, MERS in 2012, COVID is present here. And the influenza virus is yearly present, and it's seasonal, winter, summer presentation. Look at the numbers who are infected. COVID has infected over 1 million, almost 2 million people. But yearly influenza infects 500 million to 1 billion people every year. So 100-fold higher number than what COVID does. The case fatality rate, that is the number of people who with known disease who actually die from the disease. In the case of SARS, it was almost 10 per 100 patients. MERS was killing almost a third of all the patients who came in contact with it. Compared to that, COVID, the estimates are about 5 per 100 people. Influenza kills less than 1% of people who are infected. But when you add the numbers, influenza is affecting almost 1 billion people. That adds up to tens of thousands or hundreds of thousands of people who die because of influenza every year. So on the scale of all of these viruses, influenza is still the most severe one. Next slide. Okay, next myth. It's difficult to diagnose COVID. Next slide. But the clinical presentation of COVID really is non-specific. You cannot tell just from presentation whether a person has COVID or influenza. All these viruses present very, very similarly, with fever, with cough, with shortness of breath, weakness. You cannot tell just by looking at a person that they have influenza or COVID. But there's some unusual features of COVID which aren't normally seen in influenza, including diarrhea. There's an increased report of loss of sense of taste and smell. Some patients even develop an odd rash, which these bottom three in black aren't commonly seen with influenza. But these other features, which I've highlighted in blue, are very, very similar to influenza. Next slide. So how do we make the diagnosis when somebody comes in with fever, cough, and shortness of breath in this day and age? We think about COVID. We get a chest X-ray and we get a CT scan, and there's some characteristic findings on this chest X-ray and CT scan, which may point us in the direction of COVID. But the real test comes from doing the PCR test. And a PCR is basically we're taking a sample from the throat or the nose, and we're running a genetic test like a DNA fingerprint on the virus and see if that virus RNA material is present in that tissue. And if it is, these are usually very sensitive tests. And if it's positive, it indicates that the person has COVID. The problem we've had here, as you all are aware, is that it's taken us a very long period of time to develop this testing, to get the materials out to the providers, and for us to do the testing. And there are comparisons between how the Chinese and South Koreans and other people have handled it. And our process has been marred with a lot of bureaucracy and missteps. But we do have the tests available now, and fortunately, we are running these tests on a daily basis. There's a lot of questions about the antibody test. The antibody test is your body's reaction to the virus. And the antibodies start showing up normally after the virus has done its damage and has gone from your system. So antibody tests usually start becoming positive a week to 2 weeks after you've had the illness. So they aren't very much used in making a diagnosis at the time that the person is sick, but they are useful for us when we're studying to see if a person is immune to the virus, or how many people in our society have been exposed to the virus. So everyone is talking about getting the antibody test to get a diagnosis. You don't make the acute diagnosis with it. That you do it with the PCR test. Next slide. Now, the clinical course is important to understand. The majority of patients who have COVID are going to have a very mild illness. And I want to emphasize that. About 85 to 90% of people will have a very mild illness. It'll just be like a common cold. They might have a fever and a cough for a short time, and then that's done. For the first 2 days before you start developing symptoms meaning that you're having cough, you're having fever, you're having the illness itself, for up to 2 days before, you can still be shedding the virus and not knowing it. And that's why it's important in society to consider having masks and having the safe distance. And we'll talk about that later. When a person does develop symptoms, usually they last for about 5 to 7 days. They're mild and they clear off, and you do fine. A small percentage of people, however, do worse. And that's about 10% of people do worse, and that's the area in the red. That generally shows up about a week to 10 days after the illness. So they're coasting along fine. They're doing okay for the first week and think that they're recovering. Then by day 7, their fevers are still there. They're still coughing. They're getting short of breath. Those are the ones we really worry about. And these are the people who can collapse and decline very, very fast. And these people are the ones we have to bring into the hospital and watch carefully, because they can go down very, very quickly. And if they get to the point where they're sick enough to be in the hospital and then get admitted to the intensive care unit, then that's where the mortality starts to go up. Next slide. So what are these complications, which usually show up a week or two after the acute illness? persistent high fever, increasing shortness of breath, low oxygen levels when we do the pulse ox test and we see their oxygen on room air is dipping down. These are the ones who go into respiratory failure. And when they get admitted to the hospital, we see how sick they are. We see their CT scans. They also develop blood clots in their lungs. They can develop heart failure and heart arrhythmias, which can also be a cause of death. Some of them go into kidney failure, and some of them develop full shock. Next slide. Here's a sample CT scan from one of the Chinese patients. They had put it up in a publication, and this is a slice of the chest. Normally, the lung tissue should look dark, almost black in appearance because it's full of air. The white areas are where there's inflammation in the lung. And you can see this poor patient has almost his entire lung has been wiped out by the inflammation on the CT scan. And this is really what causes acute illness and requires people to be admitted to the hospital. And unfortunately, a lot of them die when they get to this level. Next slide. So speaking of death, if I get COVID, I am going to die. Not true. Next slide. When you look at the overall mortality from COVID, what we know so far, it's about maybe about 5% of people with COVID actually die. In the United States, it was 1.7, it's now approaching 4%. The Chinese kind of kept it still at about 6%. The worst off was Italy. Germany has a very good death rate. Next slide. And here on the graphical format, again, this I took from Our World in Data. It shows different countries having markedly different rates of mortality. And the reason for this is how the patients were handled. What was the capacity of the country? Did they have respirators? Did they have ICUs? Or were they overwhelmed by the infection? If they get overwhelmed with the infection, they don't have enough respirators and ventilators, and unfortunately, the death rate is going to climb. Next slide. So who are the high-risk patients? Who is at risk of dying or having severe disease from COVID? And what is coming out from all the information is elderly, above the age of 65, diabetics, pregnant women, immunocompromised patients, patients on chemotherapy, people with chronic lung disease, people with chronic kidney disease who are on dialysis, and overweight people. These are the high-risk groups. And interestingly, this isn't just the high-risk group for COVID, it's also the high-risk group for most of all infectious diseases. Next slide. So pulling up from the most widely published information, it comes from China, obviously. There's an age distribution to COVID. The vast bulk of patients are between the age of 30 to 79. It seems to be less common in the younger age group. But when you look at case fatalities, it's disproportionately in the elderly. Overall death rates in China, fatality rates were about 2.3, but in the above 80, it was almost 15 compared to the overall rate. And of those patients who actually ended up on a ventilator, it's almost a coin flip. About 50% of them will pass away despite all the ICU measures that are taken. Next slide. Again, looking at different countries, the same thing appears. The majority of people who die tend to be elderly. Here, this graph has South Korea, Spain, China, as well as Italy. The numbers are almost identical. Next slide. Moving on to the next myth, that we have effective treatment for COVID. Next slide. We are using treatments, but you need to be clear about it. There isn't any proven treatment for COVID. Everything that is being used is best guess. And we break up the types of treatments into two forms. Those that actually act on the virus, what we call the antivirals, and those which blunt the inflammatory reaction of your body to the virus, which we believe is the cause of all the lung damage. So among the antivirals, you've probably heard of all of these different drugs. Remdesivir was originally used in Ebola. It wasn't very effective in Ebola. Kaletra is a HIV medicine. Favipiravir is also an HIV medicine. Leronlimab is an HIV medicine. And then there's a lot of discussion about convalescent serum, that is taking serum from patients who have survived and recovered from COVID and using their antibodies for passive immunity against the virus. And then the anti-inflammatories, the ones you always hear about are the anti-malarials, chloroquine and hydroxychloroquine. There are these different fancy drugs, IL-6 inhibitors and JAK inhibitors, which are used in chemotherapy cancer patients. You need to understand that as scientists, we don't approve of any medicine unless it has gone through the rigors of a randomized trial, because there's a lot of placebo effect. There's a lot of anecdotal effect with these medicines. And if it worked in one person, it doesn't mean that it really works. It might just have been a fluke. So before the scientific community can actually say that a medicine works, we have to go through rigorous trials. At this point, if somebody comes into the hospital and they are ill and they need any of these medicines, none of these medicines are going to be available to them unless they are enrolled in a clinical trial. Next slide. So currently what we're doing for people who are sick and get admitted to the hospital, we are giving them the hydroxychloroquine, which is Plaquenil, and this antibiotic azithromycin. Until we have the trial information that they don't work, we will continue to use these medicines. They do have side effects, and some of those side effects are quite severe. So what we're preliminary data from France is already showing that chloroquine probably does not work. So all this hoopla about hydroxychloroquine, which is even being touted by our politicians, it really is going to turn out to be a dud, unfortunately. We do rule out co-infections. 20% of patients who come into the hospital with COVID actually do have pneumonia with bacteria, and we treat them with antibiotics. If they're developing severe breathing difficulties and they have a chest CT like what I showed you, we put them on mechanical ventilation earlier rather than later. It's been found to improve survival rates. Supportive care, then we enroll them in a trial, but you have to remember it can take 1 or 3 days before the trial drug actually gets to the patient. So if you have a family member who's in the hospital and you're screaming that they needed to be on a drug or so, that the hospital is denying them the drug, it may be because that hospital is trying to enroll them in the trial, and it can take 1 or 3 days for that medicine to be dispatched and approved for the hospital to use. It's not because somebody is trying to avoid giving a medicine. Next slide. Now there's a lot of questions about social distancing. And some people believe that it's needed, some people don't. Let's talk about that. Next slide. So I put in this graph the whole concept behind the idea of social distancing. The lower line is what happens when you have linear spread of an infectious agent. That is, it gives you a fixed number of people infected. So one day it'll give 10 people, the next day it'll be 20, the day after that it'll be 30. And that's what the lower line will show. This is how linear growth spread is. On the other hand, viruses don't observe linear spread. They observe what is called exponential, almost a geometrical spread of infection. And what I've done here is I've shown you for a virus like COVID with its multiplication rate. By day 8, the line looks very low. It looks much lower than a linear infection. Look what happens 2 days later. It goes above that of a linear growth. By day 12, it's gone into the thousands. That is how these viruses spread. Influenza spreads like this, measles spreads like this, COVID spreads like this. Remember that word, exponential growth. Next slide. Here in that diagram, I've kind of tried to show you the example. We'll talk about this R0. It's important in understanding epidemics. If a person who is infected has a virus which affects, say, 2 people, and its incubation period is 2 days, then in 2 days, it'll affect 2 people. In 4 days, it'll infect 4 people, and so on and so on. So that if by 8 days, that one infected person would have contaminated, infected 16 people. Now look what happens if that same virus is capable of infecting 3 people, not 2, but 3, just changing one number. By 8 days, that one virus would have infected 81 people. So it's multiplying rapidly. And that's what terrifies the scientific community. Next slide. So here's an actual graph about COVID. And this green line represents the United States. And if you look at this green line, does this look like the linear growth line that I showed you before, or does it show you the exponential growth line that I showed you before? And this clearly tells you in real time, we are dealing with exponential growth. Next slide. So what is this RO number? The RO is what is called the base reproduction rate. That is how fast a virus spreads. And RO, in a very simplified calculation, is C, where C is the rate of contact. That is how fast a virus affects the next person, divided by H, which is the rate of healing. That includes how fast you can treat people, or how many people are becoming immune, or including how many people die from the infection. So RO is C divided by H. Anything that increases C will increase RO, increase the spread of the virus. Anything that increases H will decrease the RO, and it will decrease the spread of the virus. Anytime the RO is greater than 1, that is C is bigger than H, you have exponential growth. And anytime you can get the RO less than 1, then you're moving from exponential growth to linear phase growth. In case of COVID, the RO is 2 to 3, which is a pretty high number. The RO for influenza is probably 1 to 2. So COVID is actually more contagious than influenza. Now, fortunately, it's not as contagious as, say, chickenpox, which has an RO of about 8, or measles, which has an RO of almost 15, which are indicating how contagious measles, mumps, and chickenpox are. But still, COVID is much more contagious than influenza. Now, we can't, unfortunately, do anything about the H with regards to COVID. And the reason is we don't have any effective treatment. We don't have a vaccine. So we can't do anything about the H part. But what we can do is we can change the number C. We can reduce C. And that's what social distancing is. If you can spread people out, reduce the virus from coming into new patients' contacts, we can reduce C, thereby we can reduce the RO, and that's what we mean by flattening the curve. Next slide. So here's another example. If you have a rate of contact of 2.5 days, that is, it's spreading every 2.5 days. And this is what the graph looks like. If you were to change that rate of contact by even half a day to 3 days instead of 2.5 days, you blunt that curve quite significantly. Now on this table, I've also shown, just as a hypothetical, if this straight line is your hospital capacity to absorb new patients and have ICUs and have ventilators, just by changing that rate of contact by even a half day or 1 day can slow that virus so that you don't overburden your hospital capacities. This is what happened in Italy. This is what happened in New York. The virus spread so fast that we overshot the capacity of the hospital systems. And that is why people are dying. They aren't getting enough ventilators for those people who are seriously ill to survive. Next slide. So what are the strategies to contain a contagious disease? Well, there are two terms that are used. One is containment and the other is mitigation. Containment is done for slow spreading infections like tuberculosis, where you have the luxury of time to identify and isolate people. In a pandemic situation like COVID-19, we move into a more aggressive phase called mitigation. And that is to do social distancing. If you had vaccines, to use vaccines. If you had the ability to treat, you could treat. But as I mentioned, we don't have the vaccines, we don't have treatment. So all we can do is social distancing. Next slide. So what does social distancing mean? It means keeping at least 6 feet from people when you're in contact. Now, we didn't come up with this number out of thin air. Experiments have been done to see how far, when somebody sneezes or coughs, how far does their spit travel? And it usually travels anywhere from 3 to 6 feet. And that is where the number comes of trying to keep about 6 feet away. The personal protection, masks, hand washing, disinfection are all part of social distancing and keeping yourself clean. You have to remember that the virus usually survives for an hour to up to 3 days, but there are some experiments that have shown that it can survive up to 9 days on surfaces. So that's why disinfection becomes very important. There's no evidence that chloroquine or hydroxychloroquine can prevent the infection. And as far as vaccinations, it's going to be another 1 to 2 years before we have vaccines. Next slide. So here's a prime example of social distancing. I've never seen the Kaaba without people, but this is an appropriate example. Schools, public sports events, restaurants, religious sites. These are the places where human beings congregate and can pass the virus from one person to another. And that's why religious centers need to stay level-headed. Ramadan is coming up soon. Then we'll have Muharram coming up. We have to be sure that we are avoiding compacting people together, otherwise the virus will spread. Next slide. There's a lot of controversy about the masks. On the left side, it's a lady wearing a surgical mask. Understand that the surgical mask can protect you from droplets, but not airborne particles. It prevents it's really meant to prevent the person who's wearing the mask from spreading their droplets into public. So think of it as you are wearing a mask in public to prevent your spit and your droplets from going to other people. Because if you remember that original slide, you can be asymptomatic for a couple of days, still shedding the virus, so you don't know that you actually have the infection, but you're spreading it. So if everyone is wearing a mask, we can reduce the spread of the virus that way. On the right-hand side is a gentleman wearing a N95 mask. They're called N95 masks because they are used in medical profession as well as in industry to prevent very, very fine, small air particles from entering your airways. And they actually prevent disease from getting to the person as well as preventing the person's disease getting to another person. The problem is these are expensive. We're in short supply, so we're using them sparingly, even in the hospital. Most of people are using the surgical masks. And then there are, of course, people doing their own stuff, which we can't really approve of. Next. So social distancing also requires changes in our social norms. Handshaking is out, but we still have other ways of greeting. And we should be adaptable and flexible in trying to avoid handshaking and hugging and close social contact. Next slide. Next slide. All right. So wrapping up, another common issue is immunity if you've survived COVID. Next slide. Unfortunately, we do not know. Now, using our experience with SARS and MERS and influenza, all of that suggests that there will be immunity once a person develops antibodies. We do believe that that is going to happen. In the case of SARS, we found that immunity can last up to 3 years after a person has survived SARS. We're hoping that COVID is the same. And it's important to know this because if we know that immunity develops, then we know that a vaccine will be successful. Because if the antibodies that are produced during an infection do not neutralize the virus, then a vaccine is not going to be able to cause immunity. It'll be a very weak vaccine. So we need to know that. The second thing is if a person has recovered and they're immune, and we know that they are immune from their antibodies, then those people can return to work. And those people can probably be recruited to take care of the sick patients. Because right now you have non-immune people who are taking care of the sick patients and they're getting infected. Healthcare workers are getting infected in droves. So if we could have a pool of people who could return to work. And that's why the antibody, the convalescent serum studies are being done to see if they actually are protective and help. Next slide. Finally, when will the restrictions be lifted? Next slide. Well, it needs to be done not emotionally, but using science. We need to have clear evidence that there is a drop in the cases. And there is very, very refined data collected all over the world, which can tell whether you're still in the exponential phase, whether you peaked, or whether there is a drop in cases. We need to study that. We have to have very, very aggressive testing, identifying people, identifying the people who are infected, screening them, tracing down their contacts, isolating them before we let the pressure off on the virus. Hopefully in the next month or two, we have preliminary information showing one of those different types of treatments are actually working. In that case, then we have some safety, like we have Tamiflu for influenza. We're hoping that one of those agents will actually kill the virus. And hopefully we also have some information about the vaccines, whether they work by then or not. But this is going to take some time. If we take the pressure off the virus right now, there will be a rebound. And that's something we cannot afford. So the preliminary information suggests that social distancing and isolation is helping. So let's keep at it. Next slide. So hopefully the virus fizzles out and we just have some odd memories of this, but I'm sure this pandemic is going to have a lasting effect on the memories of most of people. It'll probably be an impression which will be permanently etched in the minds of our children who are going to grow up in the COVID era. But I think we will get through this. Just a matter of keeping our senses, keeping our emotions in check, and we'll do the right thing. And that's the end. And if there's any questions.
Yeah, that was very enlightening session we had. And I am pretty sure a lot of our confusions and myths which we had in our mind must have been cleared by now. The floor is open for the questions. I already have a couple of questions, Dr. Shahbaz. Thanks a lot anyway. What does the flattening of the curve mean? Because that is the term which we have been hearing a lot every day if you open CNN at 6 o'clock. Does it mean that flattening the curve means decreasing in the infectivity, or how would you explain that?
Well, the example I gave in the previous one of the slides, where I showed the rate of contact of 2.5 days versus a rate of contact of 3 days. And you could see that the slope of the curve of new infections was much lower. That is what we mean by flattening the curve. The rate of infection, new people being infected, is lower. Yes, exactly, this slide. So if you project this further on, it will be a much gradual rise. It doesn't mean that we will reduce the number of people infected. What it will mean is that what it will mean is that we can stay under the capacity of our hospitals to take care of sick patients. And we have enough ventilators and we have enough ICUs available to take care of the sickest patients without overwhelming the hospital systems. Remember, people are still coming in with heart failure, they're coming in with pneumonia, other causes of pneumonia, other reasons that they need to be in the ICU, they need to be on ventilators. And where will the ventilators be for them if the COVID patients are taking up all the ventilators? We will have tremendous amount of unnecessary deaths for sick patients, not just the COVID patients. So that is what is meant by flattening the curve.
Okay. The other question we have is, we have been hearing a lot about the BCG vaccine, and that gives us a very false security for all of us who have been, born back home and have the BCG vaccine. So does it really give you some security against COVID-19?
Again, it's too early to tell. There are trials being done in England and in the Netherlands looking specifically at BCG vaccination, because BCG vaccination also boosts the immune system. And it's believed that the boosting of the immune system may be protective against the virus. We don't know. All of these things are conjectural. They have valid hypotheses, but until they have been proven in double-blinded studies, we will not have an answer. But there are trials being initiated in Europe for BCG vaccination.
Okay. And the other question is that, does viral load has anything to do with the course of disease?
Yes. We're trying to tease out why is it that there's some people who develop severe disease from mild disease. And there are lots of hypotheses, different types of immune reactions to the virus, maybe the amount of virus that you're confronted with, maybe those receptors we were talking about to which the virus attaches. There might be genetic differences in people, how many receptors they have in their lungs compared to other people. So again, these are all hypotheses that we're looking into. I'm sure there's going to be, over the next 2 or 3 years, we'll have more definitive information about this. But right now, it's too early to tell.
Okay. Another thing, people have been talking about a lot of nutritional supplements. Do you think ginger, honey, or kalonji seeds have any role in preparing us for the disease or boosting our immunity?
I don't think so. If you want to do it because you believe in naturalistic medicine and it makes you feel good, by all means, do it.
There's no harm in doing that, right?
There's no harm in it. You'll just gain a little bit of weight with all the honey, but it's really not proven to be effective. Again, there's going to be a lot of stuff out in the social media. Until it is rigorously tried and tested in a randomized trial, don't believe it. So there'll be a lot of anecdotal information and a lot of old wives' tales, and somebody B is going to tell you about it, unfortunately.
Exactly.
Be polite, but they don't really work. One thing I will mention, however, is that there is some studies that have shown that saltwater gargles may affect the binding of viruses to the cells in the nasopharynx. And there was an actual study which was done in, I believe it was in Hong Kong, where they used saltwater gargles in preventing influenza during the H1N1 swine flu epidemic. They found that it's the chloride content of the saltwater gargle that prevents the binding of the influenza virus to the cells. So they were recommending saltwater gargles. Now, whether that also applies to the COVID virus, we don't know.
Okay. Another question it came that, we know it's an airborne virus, but if it is on the surface, like, for example, it stays on a cardboard or a hardwood for some time, can it become airborne? Can it become airborne from that surface?
Very unlikely. The main reason for airborne is when the person is actually coughing, then some of the particles are in the form of droplets, but some are in the form of very tiny particles. When we're talking about droplets and airborne, you need to understand that it's the size of the particle which allows it to be a droplet or an airborne particle. If it's more than 5 microns in size, it's usually in the form of a droplet, and it's too heavy to be wafted in the air and move in the air, and it's heavy and it falls to the ground. That's a droplet. Airborne particles are smaller than 5 microns, so they float in the air, and they can float in the air in the room for several hours even. And when we do procedures on a patient, such as putting in a breathing tube, or we suction their sputum, that's when airborne particles are more likely to be released. So because we have a short supply of the N95 masks, even in our hospitals, we're using the N95 masks really only in those procedures where we have to do there's a chance of airborne
procedures. Yes.
Otherwise, in the hospitals also, we're using surgical masks. If we had a limitless supply of airborne masks, the N95 masks, then everyone would be using the N95 mask, but we do have a shortage. So we're cutting corners in a way by using the surgical mask, but the optimum mask should be a N95 mask.
N95 mask. Do you think that COVID-19 is going to be a seasonal disease only, or?
Again, hard to know. It's if you look at something like SARS virus, which is very similar to the COVID virus. Well, it never developed a seasonal pattern, and it was a one-time event. It happened in between 2002, 2003, and then it's disappeared. And it's never shown up again, because in China, in Hong Kong, and in Canada, they were able to stop the virus in its tracks. And we've never seen SARS virus again. Influenza virus is the one which is commonly shown to be seasonal. But influenza virus is a very different creature from the COVID virus. The influenza virus is genetically predisposed to mutate all the time. So every year a new virus emerges, and it emerges in the birds in China, and then it spreads throughout the world. So every year we're dealing with influenza, and influenza is clearly seasonal between the North Hemisphere and the South Hemisphere. When it's cold, it's present there. So right now we're entering spring. The flu season is dying down in the Northern Hemisphere, but it's going to pick up in the Southern Hemisphere because they're going through their fall and winter.
Yeah, exactly.
The COVID virus, we don't know about its seasonality. We don't know whether it's going to be permanently here or it's going to be like SARS and it'll be a one-time event. We're hoping that it'll be a one-time event like SARS and disappear.
Okay. The other question is like, it's for the essential workers, people who have to go to the hospitals and do their job. And if they're dealing with the COVID-19 patients in the hospital, and maybe like once or twice a week, is it necessary for them to be socially, isolated for at least 48 hours from the family?
No. What we're doing, at least in our hospital policy, is if you interacted with a patient who was wearing a mask and you were wearing a mask and you wash your hands, you're fine. If you come across a patient and you are not wearing a mask and the patient was not wearing a mask, then you're at risk of having picked up the virus. So mask plus mask means you're fine. No mask and a patient, you should be in quarantine. And if you are going to be in quarantine, then you should be in quarantine, not just from your coworkers, but also from your household. And you can come up with plans of how to isolate yourself in your own house or go to a separate apartment. And now some of the hotels in the Dallas area are opening up their rooms free of cost to healthcare workers, that they will house them for those 14 days free of cost if they have been in contact with a COVID patient. So there are means to isolate yourself if you came across somebody who was actively infected.
So if you're wearing a proper PPE and everything, and you were covered properly and the patient had a mask also, so there is no need for you to socially isolate from your family. You can come, go to the garage, take off your whatever things you have been using and change your clothes, shower right away, and you can be with your family, right?
Absolutely.
Okay.
I mean, I'm coming in contact with COVID patients on a daily basis. The only precaution that I have taken and my partners have taken is that we wear our scrubs coming to work. We have a separate pair of shoes, which we keep in our office. And before we leave our office, we take off those scrubs, put them in a bag, and we change those shoes and put on different shoes, so that when we come home, the first thing we do is we put those clothes in the laundry and have them laundered there and then. And that is to avoid bringing the contaminated material in our car and then in our home. That's the only precaution we're doing.
Okay. Another question came that what if a asymptomatic carrier can still infect another person?
Yes, that's a scary part of this. We are recognizing that before people develop symptoms for a couple of days before, they can still be coughing up or sneezing up the virus. And that's, again, the rationale behind social distancing and hand hygiene and wearing masks when you go out in the public, because you don't know if the person next to you might be an asymptomatic carrier.
Okay. There was another, I don't know whether it's true or not, but it has been going around that if you're able to hold your breath for 10 seconds or more without coughing or feeling discomfort, meaning you are COVID-free?
No.
All right. Yeah. Another scenario came, Dr. Shahbaz, that right now we all know that the testing is not available as many as we want them to be having. If a patient has all symptoms of COVID-19, but somehow was not able to get a testing done, but he or she is having short COVID-19 symptoms, get better, now afebrile for 48 hours, how long should she wait to come out of a room and start meeting with the family member, at least not going out, of course, for, I would say, but I mean, once she's afebrile for 48 hours and she's feeling much better, everything looks fine, can she come out of the room and meet with her family members?
Yes. The general instruction we are giving to our patients who have COVID, diagnosed, confirmed COVID, is when they have cleared their infection, that means the fever is gone, their coughing is improved, they're feeling better, and they have been without symptoms for at least 3 days from the last fever and the cough, then they can come out of isolation. But we still recommend that all their daily activities, when they are out in public, they should still wear a mask for up to a week after. So they have no fever, they have no cough, but they will still wear a mask for at least a week after they have recovered, because we are finding the virus, parts of the virus still being shed in people's cough for up to a week or 2 weeks after. Now, it's not living virus, it's probably just the genetic material that we're detecting. But just to be on the safe side, we're suggesting 3 days being symptom-free, then you can wear a mask and come out in public. And by the end of that 1 week, the chances of your infecting anyone is very, very slim.
Regarding the pediatric population, that children are not showing as many complications from COVID-19 as our adult population, but they are definitely can be a carrier, right?
Yes. Children, for whatever reason, children seem to be doing very well with the virus. They just have a mild illness. There are very, very few reports of mortality among all the different countries among children essentially under the age of 19. But children, as you know, you're a pediatrician, children are petri dishes, and they are living with their parents, they're living with their grandparents and other people. So they can pick up the infection and they can be spreading it around all over the place. So it is serious of them being a source of infection for vulnerable people.
Exactly.
But the virus itself doesn't do much harm to them.
Okay, do we have any data for the pregnant female getting COVID-19 and passing it on to the babies? The vertical transmission?
There's not any vertical transmission. That means that the mother passes it to the baby and the fetus. But if the mother gets ill, then it is a serious illness. And if the mother gets seriously ill with high fevers and all, that can affect the baby. Plus, pregnancy is a lowered immune state to allow the mother to house the baby. And pregnant women do worse. That's why I included pregnancy in that high-risk group of people. So pregnant women can develop very serious illness, and it's dangerous to them. And because of that, then it's dangerous to the baby.
Okay, I think that was the last question we had. Thanks a lot, Dr. Shahbaz. I think it was really helpful. A lot of confusions have been cleared. Hopefully, our community will come out of this pandemic successfully. And take-home messages, social distancing is very important. Hand washing is very much important. And only the few slides, the second slide when Dr. Shahbaz showed us that which sites are more, giving us the information 100% correct. Just go through those sites and do not act upon any other messages which we are getting. So that will really, curb down our all confusion. So thanks a lot, and I think we are done for today. And hopefully, people, if you have any other questions, they can call us afterwards. Also, they can text us, and hopefully, on behalf of CFK, I'm thinking and I'm hoping that we can continue these kind of discussions on certain other topics also in future. So thanks a lot, everyone, and that's all for today. Thank you.
Thank you.